that when we're ready to go.
Okay. Okay. Good afternoon. We thank you in our cyber audience for joining us for today's program, Next Steps in the Struggle for Reproductive Rights. This is a Women's History Month program sponsored by the Tompkins County Office of Human Rights and Cayuga Health. I'm Ken Clark, Director of the Tompkins County Office of Human Rights. I am joined here today by two accomplished and respected community leaders who will discuss the implications of last year's Supreme Court decision that overturned, Roe v. Wade, which for nearly 5 decades granted women reproductive autonomy. For the first time in American history, a right originally granted by the court, as the Center for Reproductive Rights noted, as fundamental to personal liberty, was canceled by the court. Our guests will also discuss the local and regional impacts of the decision, given that New York State protects reproductive rights by law. Additionally, they will share their perspectives on the way last year's decision impacts the most vulnerable populations of women in American society. These are among many considerations that require further scrutiny and serious reflection by all Americans, irrespective of where one stands on the debate. Today, we are joined by Dr. Anna Kellis, New York State Assemblywoman for the 25th District, which includes Ithaca, and former member of the Tompkins County Legislature, and by Dr. Jada Hamilton, Interim Chief of Clinical Operations and Service at Cornell Health. We will begin with comments by Dr. Kellis, followed by Dr. Hamilton, and we will go from there and ask you at the time following their presentations that you would submit any questions or comments that you have in the YouTube chat. Thank you very much. We'll lead off with Anna beginning our conversation.
It's wonderful to be here. This is certainly a topic that is near and dear to my heart, and a topic that has been quite heated here in the state capitol, because there is a very strong commitment from the majority in the Senate and the Assembly and the governor's office to ensure rights or to reproductive rights in New York State, regardless of the decision at the federal level. And I wanted to start by noting one of the things that we did last year that, of course, we will do again this year, and I can explain. We passed a bill that would enshrine the protections of reproductive rights in the Constitution of New York State. If you are doing an amendment to the Constitution, you have to pass that legislation in 2 consecutive legislative bodies. And by that, I mean not 2 consecutive years, but that it has to be a different legislative body, the 2 of them. And because we had an election last year, there's a significant different legislative body this year than there was last year. And legally, it is considered a different body. So we passed it last year. As long as we pass it again this year or next year, meaning in the next term, it has to be 2 consecutive terms, then it will go to the ballot. And I'm sure there will be a lot of publicity about that, but I am hopeful, given what we have seen publicly in the polling that has been done publicly on preserving the protection or preserving and protecting the right to reproductive rights. I feel that this will comfortably pass in New York State, but we will still have to fight for it. We should not rest on our laurels. That is going to be extremely important. But we are in New York State doing many, many other things that will increase access, not just enshrining the right, but just because we have a right in New York State doesn't mean that people actually have access to it in New York State. So there are 10, 15 bills, many out there that protect different aspects of access to reproductive rights. There's a bill that is in the Senate one house right now, and not in the Assembly one house, but that is more of a policy practice by the Assembly not to put in policy pieces into the budget. But because it was in the Senate, it is on the floor, and it is a fund. This is really important. It is an abortion provider training fund, and that would provide both transportation and training costs to medical providers to gain a knowledge in reproductive rights. And why this is really important is because not only are reproductive rights being taken away in other states, but in those same states, they're actually pulling out any education on reproductive rights in their medical schools. So they're trying to annihilate even the knowledge of how to do reproductive rights in the context of abortions. And of course, you do that enough generations and the understanding and knowledge and ability to provide that service disappears. So we are trying to secure to even that extent to provide a fund that would enable people from other states that have been negatively impacted to come to New York and get the training that they need and bring it back to their states. We have other supports that would programs, funds, bills that would create funds like the Reproductive Freedom and Equity Program. And it would not, it's not about only providing financial aid to support the operations of the providers, which we suspect is going to increase over time with people coming from out of state. But we also have to recognize that the majority of people who seek abortions are people who already have children, are women who already have children. And so part of the decision, of course, of having an abortion is the consideration of, will I be able to continue to take care of the children that I have if I bring another child into the family that I have now? And so part of even being able to access an abortion is being able to physically drive there or take transportation and have childcare, someone taking care of your children while you're in the clinic. So part of this fund is the wraparound supports even. Like that's as far, that's the magnitude of the conversations that we are having in New York State that I think are really, really, really important. Other things that we're doing, there's a bill that would require medical, the medication abortion services at all on-campus student health centers at colleges in both SUNY and CUNY. So that, of course, in the student population, it is there. We passed a bill in the Assembly yesterday that would enable teenagers, it did not have a lower end age limit, who could get a prescription for access to birth control without the explicit consent of their parents. Because we know that just because you're not talking to your kids about sex doesn't mean they are therefore not going to have it. But if you don't have the conversation and you don't enable them to protect themselves, then you're setting them up for failure. And I was encouraged by the fact that there were some, it was bipartisan to some extent, because there were some Republicans who acknowledged that if you enable adolescents to have access to birth control pills, you will see less abortions. And if your concern is about reducing abortions, then you should support having access. And I appreciated, it wasn't many, but there were some, so it was bipartisan. And I don't want to take up the whole time, but there are many, many, many things that we can do to create access, but specifically equity and access in how we provide the supports and the protections. I will end by saying last year we did pass a series, a package of bills. I think it was 6 or 7 bills very quickly after the decision at the federal level. And most of that focus was to protect in every way all of our abortion providers and reproductive rights providers in New York State. That there was safe harbor provisions and protections from other states trying to sue doctors here in New York State for providing care to residents of their states. Those were some of the types of protections that we put in place last year. So we're doing phases, and I am very hopeful that we do another package this year. That's certainly something that I am championing to see some of this legislation that I spoke about put in place so that we have the protections, but there's true access. I'll end there.
Oh, are you still muted? I think. Okay.
Yeah, thank you so much, Dr. Kellis, and now Dr. Hamilton.
Yes, thank you. So I think, I mean, I'm a physician. I'm a family medicine trained physician. I, spent a lot of my career in the United States Navy. That's where I retired, and now I'm in college health. And I think, as a cis woman, as a mom of a daughter, and have sisters, I think this decision really has sort of dire implications related to, obviously reproductive justice and just a woman's ability to have agency in her health and her, body. And it should be a decision between her and her family and her, clinician, who, whatever if that's appropriate. And I think this really is going to be a hard battle for a lot of women in states that are not so fortunate to be in New York State, but it's going to really, we really need to continue the fight. And as we already know, that women of color already face significant health disparities in maternal and infant health. I mean, we have the highest among Hispanic women, white women, Asian women. Black women have the highest mortality rates related to pregnancy. So on top of that, this is another barrier, another piece of not having equity in our health and wellness. And I think it's gonna be significant, and it's gonna take a lot of assistance from our policymakers, our people who are advocating, in addition to me personally and my friends and colleagues, to really get out and vote for really what is needed for our community in our state, and hopefully for the United States at large. And I think this also, I think about this decision, and I also think about what's next. What other right and opportunities that can be taken away from a lot of marginalized, underrepresented populations that could be really impacted, and also the criminalization potentially of seeking an abortion from another state. And of course, people of color are already criminalized for the minimalist thing. So this is another added dimension to this. And fortunately, I'm so glad to hear about the safe harbor provisions, because as working at a college health campus, obviously in a college health center, we have students from all over. And so am I going to be at risk for providing a medication for someone who needs it, and then they go back to whatever state? Is that going to be an issue? Like, what's going to happen? And I think there's a real fear about that. And I definitely think is for us to be able to feel safe to provide the care to people who need it is really going to be key, and making sure that we are able to do our jobs and not be in fear of some sort of litigation or going to jail. I think that's a big piece of this. I do think there's also another fear of mine with the medication abortion treatment, in that pharmacies carrying it, or what kind of ramifications for certain pharmacies that actually are able to carry it? Are people going to boycott, or there's going to be some other sort of protests that are impacting the safety of people who need to go to that place to get prescriptions and things like that. So I think that's going to be another issue. Again, I think I'm really lucky to be living in a state that is, really putting these protections in place. But again, I think that, we still have to keep up the fight. And of course, I mean, when we think about abortions, like Dr. Kellis said, most of the women already have kids, right? It's not it's not something that's taken lightly. This decision would basically provide, just additional barriers, additional inequities in health and wellness. A lot of states already have bans, obviously, to, for physicians or clinicians to be able to provide abortion care, abortion treatment. And a lot of the women are Black. They are, like I said, they have, kids mostly. But if they come from Southern states, a lot of the Southern states already have access to care issues to begin with. And what comes with that is also, less access to even just sexual health care and contraceptive counseling, and just having that information to be able to make, choices depending on what's going on in your life. And then Medicaid and federal funding pieces also, where if I'm underemployed or underinsured or, have needs and I'm covered by Medicaid, there's many states that actually, we cannot even use federal funds and Medicaid funds to even provide abortion care. So I think that's another big barrier. And I think, that's going to be another big piece of this as far as access to treatment and care, so to speak. And then, as Dr. Kellis had mentioned, the whole piece about how do we improve access, transportation, if you have to go across state lines, who has extra savings to be able to, take the trip and get a hotel, or if you don't have a car, who's going to rent a car? It's pretty detrimental. And then on top of the extra risks of mortality for women of color, just being pregnant or, having a baby, this is just going to, impact even more, because it's not going to get better. This process is not going to get better. So I think there's still a lot of work to do, like we said. I was trying to meld all the questions together, but
yeah, I was thinking the same. Ken, if you have any follow-up questions for us, because
and it's interesting that most people in this country actually, favor a person's right to choose, correct, right, and are not and don't agree with criminalization of abortion and that kind of thing. So it's just interesting how this really counters
the bipartisan support.
Yeah.
Right. Yeah. Right. Exactly. Yeah. Exactly. And then so it's just, it really is. It's a hard thing. It really is.
I think it kind of spells, it's sort of symbolic of how in many ways we have, you can look at it on a spectrum of issues. And this one in particular, it sort of has highlighted the discrepancy between what large segments of the American population support over against the political commitments of the people who represent those people. It is particularly in the states where reproductive rights have been basically eviscerated. And so it's, that gap exists there. And that's a real issue in particular.
Right.
One of the things, that I picked up in terms of your conversation was the issue of creating equity and access. And if you could talk a little bit more about that, I think each of you touched on it in some ways, but if you could elaborate a little bit more on that piece, what would that look like, or what would be a vision for that under these current circumstances?
Well, part of the piece about access is if you don't have any reproductive rights services near you, then it doesn't matter whether it's legal or not. You're not going to be able to access it. And even despite the support of reproductive rights in New York State, in the more rural upstate areas, and even some urban, because it is not a moneymaker. As hospitals make decisions about staying solvent, they make decisions of leaving behind reproductive health, women's health, so OBGYN, gynecology, and that is a major crisis. So if you have to drive 2 hours to get any support, then we don't have access. And I would say that is a serious problem. There is a bill by Senator Leah Webb and I think Assemblymember Gonzalez Rojas. It might be Assemblymember Clark. I've got to try to remember. We have already 10,000 bills out, I think. But I think this is really important that it's just a study bill, that it would require the tracking of where all the reproductive rights services are in New York State, so we can see where the deserts are. And then we can start to fund and support making sure there's reproductive rights. Also, what I spoke about before, and it's not flippant. There are people who literally do not have the ability because they don't have anyone to take care of their children. They don't have anybody to get them to the provider. And they can't take that many hours as a single parent away from work. You have created a situation where that person cannot get access to abortion care. And there are families that make decisions based on their ability to simply get access. And that is discriminatory, obviously, based on income. And very, very often you find Black and Brown families much more often in that situation, and therefore it's also a racial issue. So it's a combination of all of those things, and that doesn't even cover probably all of it, but that paints the picture, I think, that's important.
Right. And I'd like to add, thank you. I'd like to add that, so as far as you can't have equity unless you have access, right? I mean, that's it. You have to have it.
Right.
And I think, thinking about the race piece, there's structural racism, right? So, and I find it interesting that, a large percentage of women who seek abortion care are Black or Hispanic. And it's interesting how that impacts that group who, by historical date, by history experience, we, our lives aren't really that important, with the history, with other things that have happened in the past, and medical experimentation, et cetera, et cetera. So it's not, taking away something that impacts mostly Black and Brown people, that really is a surprise, right? As far as the access piece, I think there is, I think what COVID has taught us that we can actually provide care over telehealth. So even in those rural areas, making sure people have access to good internet services and access to maybe, a computer or something, if they need to go to a private space in a library, because the medical abortion care can be done over telehealth. As long as, you have, good dating and, they're within the, certain number of weeks, that makes it appropriate because it's very effective over 99% of the time. So, thinking about how we can expand access other than just having somebody come to a building, leave their family, drive 2 hours, how about that? How about being a little flexible? And that's something that is definitely a possibility, but it does take, some infrastructure and some support. And then at least hopefully one day avoiding like those healthcare deserts. It's just, but it's so hard, to, attract primary care to certain areas. There's a shortage in many areas. So it's, or GYNs, it just kind of depends, but it can be medical abortions can definitely be provided by, your family medicine person, GYN, et cetera. So yeah, there's a lot of work to do still.
Well, and of course, this is also totally wrapped up in whether or not we will continue to have the ability to have medication abortions, mailed.
Mm-hmm. Yes.
And that allows
Yes.
for entire telehealth support.
Exactly.
So that will affect New York, and we'll watch certainly very closely.
Yes, unfortunately.
Dr. Hamilton, I have a question actually for you. One of the things that is also tends to be a big problem is a trust piece. And what I have seen of the data, but I'm curious from your experience, specifically among OBGYNs, the diversity. So if people are going only to white doctors and they're asking, and they have no ability to relate to any aspect of their lives, it can be much harder to feel safe. And that is also an access issue. And my understanding is it's still right. It's still predominantly white.
Yes.
In the OBGYN. I know that it's different in some, but still even in OBGYN.
Yeah. And still yes. And of course it depends on where you are, right? I mean, if you're like the urban city, but if you're in Atlanta, Georgia, obviously you're gonna have more of the people who look like me, who are my, gynecologist or doctor, versus Ithaca. But I may be wrong. There maybe have some new people. I have to double check. But I'm open. Yeah. But I do agree that trust piece. I don't think, I think when we think about trust, Black women of color, Black people trusting, physicians who may not, have the same lived experience or even look like them. I think there's definitely historical stuff that's, in the mix. However, people of color are still facing, disparities in how they are treated, discrimination, racism, call it out, even today. Right. So it's not like it's something that's in the past and it's the past, but that's why we don't trust. But it's actually things that are continue to happen today. So I think it's imperative that our community healthcare people somehow are out there in the community to just make sure that, that they can demonstrate, hey, you can trust us. We are, engaging in culturally humility, training programs. We hear you, we see you, that kind of thing. But it's something that, I honestly think as far as the medical profession, just like we have to study for our boards and our, recertifications and get so many continuing education, medical education hours per year, culturally, impactful humility training is part of professional development, right? I don't know that it's across the board, but we're trying to move the needle. I think, thanks to Herb Alexander and his wonderful work at the health systems. But I think it's just something this is part of what we do. We care for people, and how do we best do that is making sure that we care for them respectfully, and we understand where they're coming from, even if I've never had that lived experience. But I can definitely empathize and not make assumptions about, oh, you're just so and so and you want this procedure because you're whatever, lazy or stupid, or you just don't know how, why didn't you use birth control? Except there's so many bad things that people say about others. And but yeah, that's part of it too. So there could be, we can all learn.
Right. And there's more even to all of this. The trust piece really is actually a piece of access. If you look at the data, women are inherently treated differently than men. For example, the amount of pain a woman has to be in, and an advocate for herself to get even attention is significantly higher than men, and it doesn't matter the sex of the doctor. And so there is discrimination against women in pain, and women are just, being emotional and, must be her, menstrual cycle. There's still, the data shows that. And then if you add a second layer to that, which is that Black women are much more likely to have higher rates of maternal mortality
Mhm.
than white women.
Mhm.
And
Mhm.
what's even more telling about it is
Mhm.
that Black educated, like secondary
Yes.
education and higher,
Yes.
are more likely to die in
Mhm.
maternal mortality than white women who haven't graduated from high school.
Mhm.
So I'm, no
Yes.
judgment of anybody's education level. I'm just saying,
Mhm.
looking at the data, that shows a level of racial sort of differences. And
Mhm.
a lot of it, in that research is showing just the microaggressions constantly lived, experienced, the strain on the body creates a physiologic environment
Yes.
that puts Black women more at
More
risk.
stress. Yeah.
And then on top of it, you have the experience of women having negative experiences engaging the medical system because they are treated unfairly. You put those two together and you may have women who are, have to make the decision of, I'll have a fourth kid, it's going to not be safe, or I engage with a system where I feel totally unsafe. And they might weigh that the hospital system, the medical system doesn't feel accessible. And that may be a part of what's weighing decisions. So when you're talking about accessibility, there are a lot of pieces to it and nuances that we have to be honest with ourselves. So there are pieces we can do by legislation, of course. And then on top of it, we have to acknowledge, as Dr. Hamilton, those are some aspects of the structural racism that we have to, sexism and racism pieces that are influencing what we're seeing.
And
Please,
just
the social
I'm sorry.
determinant.
Oh, go ahead.
And
Oh, I
the
was just
social
gonna piggy. Oh, okay. Sorry. I was
That's
just gonna
okay.
piggyback. I just quickly before it goes out of my head. I mean, Dr. Kellis did mention about the pain, experiences for women versus men, but also being a Black woman. So there's already, University of Virginia did a study back in 2016 about, basically surveying like medical students and residents about the pain, like perceived pain of Black people, and there was a unfortunate opinion that we actually don't feel pain as much because of some non-existent physiologic thing, that our skin is thicker, our blood clots, more quickly, our nerve enzymes are less, sensitive. It's craziness. This is like not too long ago. And so when you think about mortality, morbidity related to like pregnancy related things, if I'm having pain and it's related to potentially likely a poor pregnancy outcome, then I may not be believed because, she's not that much pain. It can't be that bad.
Right. Well, but the thing is, Dr. Hamilton, it's so funny because it's really the opposite. If a woman comes to the hospital and she's saying she's in pain, and we have done studies that there's some studies that do show that women have a higher pain threshold and tolerance. If women have a higher tolerance and they're coming to you saying they're in pain, then they are probably in a lot more pain even than maybe the average female.
Right. That's exactly.
So it's really the opposite perspective, right? I mean, it's just sort of mind-blowing to me, but we do acknowledging that there are all of those biases is really important. I just wanted to note that there was a question. The question I'll just read to everybody: most low-income people who would need access to reproductive health services live outside of town. What about TCAT donating monthly passes to medical providers to give low-income residents to make it easier to return for follow-up appointments? It's a very creative idea. Maybe we could also fix the public transportation system, that the state gives more money to upstate transportation. But we're fighting for that. There are really creative ideas, absolutely, that I think we should do. That is a conversation. I do know that TCAT is really struggling and pushing hard to make sure that they continue to have funding they need currently. So it would have to come from the entities that provide the funding to TCAT, like Cornell, having a serious conversation and increasing the funds they're providing to TCAT, along with the city and the county, and then that could be put on the table.
And I think, I mean, I don't know this for sure because I stopped taking a bus a long time ago just because the routes were less convenient for me. But I don't know what it's like for staffing too. Like a lot of places, the pandemic hit and then people were like, oh, do I need to work doing this anymore? So I don't know what the kind of, if there is a shortage of drivers, if, because I know that can impact, how do we get people to come to this area to be bus drivers or have those, have those services, because it really has been limited since it's really gotten pretty.
Yeah, or is the pay
hard
for drivers here competitive?
Yes,
Than
exactly.
drivers in other regions. Yeah,
exactly.
That's a very good point.
Right. Yeah. So you may have the funding, but if you don't have enough bus drivers to drive your buses and get to where you need to go, it's going to be really, really difficult too.
Yeah. No, and it is a really great point, though, acknowledging that it is. We have a situation in Tompkins County where if you are very low income, you're more likely to live outside the city.
Yes, exactly.
Which has less access to transportation.
Exactly.
Exactly. So yes, it's a very big problem, and we are aware of it. But in my mind, that the other piece of that that's really important is continuing to enable telehealth and medication abortion, and being able to get that at the convenience of the woman who is seeking the care. And that would also address some of this. So that's an area that is more under our control, that we can fight for us, certainly at the state level.
Yeah, that's a big one.
Yeah.
The one thing I did want to do, Reverend, if that's okay, to give the list, just want to make sure that people know these rights have been secured in New York State. This is a summary of the bills that we passed last year.
That'd be really
So one of them was the protection of malpractice coverage. And that was sponsored by Senator Hinchey. In the Senate, I can't remember who in the Assembly again. This was last year. I'm trying to remember yesterday, given that we're in budget season. But that prohibits medical malpractice insurers from taking action against a healthcare provider in New York State and for performing legal abortions or other reproductive healthcare needs. So that, Dr. Hamilton, I wanted to make sure that you were aware of that.
Yeah.
And there was another one prohibiting medical misconduct charges for performing reproductive healthcare. And those were specifically protecting licensed medical professionals from misconduct charges for providing legal abortion to out-of-state patients. So that was the second one I wanted to make sure that you were aware of. A third was the freedom from interference with reproductive health advocacy and travel. That established a cause of action for those who unlawfully interfered with the rights to reproductive health care. And that one I thought also was really important. And then we had a confidentiality program, and that was designed to add employees, volunteers, providers, and immediate family members of anyone in those in those groups to address confidentiality program. That one's more complicated, and I can follow up on that one, but that was specifically it was the address groups to the address confidentiality program. So the emphasis of that word makes it a verb versus noun, but the address confidentiality program. So it adds employees, volunteers, providers, and immediate family members of anyone in those groups to the address confidentiality program to protect, right? Because if a doctor's family is being threatened, that affects the family, the doctor's decisions. So it goes beyond just the doctor. And that one was super important. There was an extradition and discovery non-cooperation bill, and that one prohibits New York State from participating in out-of-state cases involving abortion. And there was a few exceptions in some criminal cases and in some civil cases, but outside of those specifics, then this bill applies. And then the last was a study of the impact of limited service pregnancy centers. And that one I think is also really important to get clarity on what that means and those entities mean, and making sure people are educated.
Right.
There are the CPCs, they're the Dr. Hamilton, what does the CPC stand for? It's the pregnancy centers. There's a lot of education that's needed about pregnancy centers because they are created by religious groups. And, there's some centers I've talked to, people who work there, that feel that if someone is choosing to have continue with their pregnancy, they want to provide support for them with that decision. But there are a lot of concerns. I have a lot of concerns, a majority of them, if not almost all of them. And I can't say all of them because I want to be respectful of humans in this process. But what has been documented is that it is with the intention of connecting with women who are in that very precarious moment where they're seeing pregnancy as a risk, as something that is causing them great stress, to catch them in that moment and convince them to continue the pregnancy. And there are things that are done where the clinic, it's put right next to a Planned Parenthood. Everybody wears scrubs. They offer all services free. They offer, sonograms so that you can determine, how far along you are in the pregnancy, but offered for free. All of those things then draw women in. And then the focus is really, hey, here's all of the risks of having an abortion. Here's all of the problems, and really here's all the supports you have for having a baby. And there are a lot of case accounts, and I've talked to a bunch of OBGYNs who've had the experience where a woman will go get a sonogram and then connect with Planned Parenthood, and Planned Parenthood will do a sonogram and find that their estimate of how far the woman is along is much less far along than was told to the woman. So there are issues. And that is why there's an investigation that needs to be done across the state on what truly is happening, because it is, if you're wearing scrubs and you look like a nurse, anyone can wear them. There's no law saying you can't wear them, but there are very few people in the CPCs that are actually registered nurses or in the medical field at all. So again, those are some of the concerns, and that is why that bill was part of the package.
Oh, that's fascinating. Oh my gosh. Not in a good way.
Wow.
There's a lot of pieces going on here. But those were all the bills that were passed last year. So I just wanted to make sure that everybody was aware of the rights that have already been established into law. And particularly, Dr. Hamilton, make sure you know your protections to the best of our ability.
Thank you. Yes.
I was going to say that you addressed the concern that Dr. Hamilton raised earlier about, providing support to someone out of state, and not have, and wondering whether there will be repercussions for that.
That's good to know. That's not perfect.
Yeah.
It looks like, is there
another question
in the chat?
Yes, and this is for you, Dr. Hamilton. It says, Dr. Hamilton, I've appreciated your thoughts on this before. Can you speak more on how important representation is when it comes to this issue in regards to race?
Yes, absolutely. I mean, in an ideal world, if we were all perfect people and it wouldn't matter, it's not matter, but it wouldn't be that much of an impact. However, there are studies that show that, for example, Black patients who are cared for by Black physicians actually have better health outcomes, and the patients are more likely to follow whatever medical recommendations and things like that. So I think there is definitely something to be said. I think definitely if we could have more diversity in healthcare and physicians and things, that would be wonderful. And that's just one benefit of that. It of course doesn't hurt for all of us to be able to provide culturally appropriate care and be willing to listen to every patient, treat them as a person, and not, hopefully we all have biases, and that's a whole discussion. But yes, it does help outcomes and helps people feel, helps their health if they have somebody who, especially for Black patients, have that person that's caring for them also be Black. So but it's I mean, still we're 13% of the population about Black people, and then maybe I can't remember the most recent data about how many physicians practicing are Black, but maybe about 5%, 5%. Yeah, and it doesn't seem like, students are that interested in it. I mean, they could do other things, go engineering or law or, business and things. So it's been a struggle to attract students of color into healthcare, and medicine, because, it's a long haul. It's, it's not cheap. So yeah, but
And if
we're trying.
Yeah. And Dr. Hamilton, isn't it the case that there's a lot of discrepancy in pay for doctors, but you all have the same medical school debt, and of course OBGYNs don't get paid as well, right?
Oh, OBGYNs, well, they get paid well, but they have a high insurance, they have high malpractice insurance.
Right.
Unless you no longer do OB, right? So that's the other thing. A lot of, they can, no longer want to do deliveries and all that kind of stuff. But yeah, right. And I think, so if I have a high debt, I'm probably going to pick the higher paying specialty versus primary care or working in underserved areas and things where my salary may not be like if I'm working in like Chicago or Atlanta. Right. And that's why I did the military thing. I got a scholarship and I didn't have any medical school debt. So I was, thankful for that, but that's, there's a ways to kind of navigate, but then you have to know people you have to know about it to actually, and I was fortunate to like have some family members who kind of knew about the program and, encouraged me to apply, but, you have to know these things, right?
Right. And would you say it's the case too? I would think that because we have this structurally racist system, people who are Black and brown going into medical school are ones who are more likely to be coming from lower income situations, and therefore less likely to be able to take on a field that is going to be less financially.
Right. Or even if, they may not have people in their family or, somebody who knows somebody who's a doctor, you could like get some shadowing, or somebody could talk you through, how to apply and how do you pick your major and all that kind of stuff. So it's kind of one of those things where you almost have to know someone, but it definitely is more of a challenge if you're just going, like you're the first to go to college. So you're going to be the first to go to medical school. Like, what is that like? And how do you navigate, bad days and bad call days and, all this kind of stuff. It's good to have those sort of, people you can lean on and, So we need more. I don't know what's going to happen, but
Well, I think that what this conversation, to me, even being a part of it, has really outlined is there's no handful of bills that is going to solve the access issue. That it is deeper and broader than that, and we're not going to be done once we pass like another 10 bills. This is a lifetime for all of us. Me as a legislator, just the next thing, once we get these, then we work on the funding, and then we work on schools and high schools, and what about education in high schools?
Yes, that's a whole other.
I
know,
it's just endless.
Yes, it's endless. It's like that,
but that's okay.
Yes,
we got
yes, that
we're dedicated, we're committed
approach. Yes, exactly. Yeah, absolutely.
I've got a question for both of you as we move toward the end of our time together. What would you say to everyday citizens in terms of what can they take from what we've shared today, and how might they respond in a way that's empowering for them to this reality?
I mean, that's a great question. It's complicated.
I know.
I would say, one of the
I made a living out of this.
One of the things that I'm hearing, for what it's worth, and this is more on like a sort of emotional, spiritual level, that I'm hearing from people, one, a deep sorrow for what's happening in other states, and also sort of a thankfulness that they're in a state that's so committed to protections. And I'm glad for that. I'm glad that we're fighting for that. I think that we should not overlook, though, the subtle trauma that women have experienced across the country, hearing the message that we are once again a second-class citizen officially, and that we shouldn't think that it doesn't affect everybody, and maybe having some like understanding, compassion. We women should check in with each other. We should talk about it. It is there. I absolutely feel that way. And when I get quiet, and I've been asked sometimes to speak in pressers on this topic, and I'm in front of all these cameras and I'm talking about it, and I realize I get deeply emotional. I had 2 abortions when I was in my 20s, and I was in an abusive relationship. And I would be connected in that for the rest of my life.
Yeah.
Once I wanted to have children, my autoimmune disease kicked in, and so like I've dealt with, and it's deeply emotional topic, but it was my choice, and that was the most important thing. And the idea that is even under threat for any woman across the country is at my core painful. Anger. I have every feeling. I want all, everyone in across the United States being sensitive to each other, being aware of it, supporting. That's like very subtle and like ephemeral answer to your question in a way, but I don't think we should discredit even the subconscious impact that this decision has had on all of us.
Right.
No. But I think it's a humane response. I mean, it really speaks to how do we understand, how do we seek to be empathic or put ourselves in a position to hear another person's reality, one whose gender is different from one's own, whose experience is different, who it lives at the intersections of sexism and racism and other types of dynamics that inform one's identity. How are we sensitized to folks we live with, whom we live and interact with, and who are around us, our neighbors?
Right. I think too, just with Dr. Anna, Dr. Pellis, Dr.
You can call me
Pellis,
Dr. Anna. I love it.
Dr. Anna, mentioned, and I totally agree. And I think it's all about sort of this, we all carry our history, our burdens, our challenges, and you don't know what anyone else is going through. And you cannot make assumptions about their decisions and why they made them, et cetera, et cetera. So I think that's empathetic, just we're all human. Right. We all have our stuff, and we can, treat each other without judgment. And I think also, even if something doesn't impact me directly, how can I sort of elevate, amplify the voices of those who may need help in sort of getting those messages across? Just because it doesn't impact me, but I care about people, and I'm going to help making sure that we all can be as healthy and as well as possible. And if that means, even if I don't have kids in school, that I can influence something, education wise, we're making sure that students get, information they need, because information is key. I mean, who gets access to that? Which leaders we can ping to say, hey, I really care about this, this issue. What can you do? And just being engaged with your community, even if you think certain things don't really apply to you. But I think it's sort of that doing the greater good, which I think we saw a little bit of that wane a little bit over COVID, right? I mean, people, the other states, I'm not going to say anything else about it, but the masking and how, this is my body, I, can do whatever I want, even though people around you may not, may need more protection, right? And public health. I mean, we care about the public health piece, and yet there was definitely some problems with that piece. So I think it's just about that empathy and treating people with respect, and we all carry what we carry. There's sort of this trauma-informed approach where, we all play a role.
For one thing, that could be a very tangible thing that people could do is the Equal Rights Amendment, which was the amendment that we voted on last year that will protect abortion, reproductive access to reproductive rights, will be on a referendum either this year or next year. And
People need to
want,
yes.
read up on the Equal Rights Amendment that was passed last year.
Mhm.
Support your legislators and
Yes.
voting for it this year,
Mhm.
and making sure when it is on the ballot that you educate every single person you
Yes.
can get your hands on
Exactly.
to vote for it, to make sure they go to the polls.
Right.
Because
That's
I
key.
truly believe the more people who go, the greater the likelihood of it passing.
Exactly.
So get people out to vote.
Get them to vote. Go out to the polls. That's so important.
Yep.
So important.
Civic engagement. But if you Google, the Equal Rights Amendment 2022, you'll get a million articles about it. You can read up all you want about it.
Great.
Thank you all both so much for this just
Thank you.
wonderful and enriching conversation, and for reminding us in a real sense that, basically we are in a relational world. Whatever affects any of us directly affects the rest of us indirectly, as Dr. King said, because we talked about being caught up in a inescapable network of mutuality tied in a single garment of destiny. And that is at the crux of what we need to address and understand, coupled with the need for law and legislation and policy that will produce just outcomes. And
Absolutely.
thank you both so much for what you shared with us today, and thank our audience for joined us and for the questions that you sent. And we will this will be on the Tompkins County Office of Human Rights page on YouTube for future viewing. So again, thank you all for joining us, and we bid our online audience a good afternoon and a good weekend.
Thank you.
Absolutely.
Thanks for the opportunity.
Thank you. This was wonderful. Wonderful to see you both.
You too. You as well. Bye-bye.
Yeah. So I think Rob will.
Okay.